it's 4 o'clock, so let's get started. I can see lots of you joining us now. Hello. Hi everyone, I'm Josie Jenkinson. Welcome to our 4th Old Age Liaison Network webinar. We're very happy to have over 400 people registered for today's session on Mental Health Act, Mental Capacity Act interface in the acute hospital. So I'm Josie, I'm one of the founders of the network, your host for today. You should be able to see the other founders of the network on screen. So we've got Liz, Mark, Annabelle and Krish, and also our great speakers for today, Chloe. And we've got Jeremy as well. Sorry, just to start with a little bit of housekeeping. So please say hi in the chat function, be friendly, your role, where you're joining from. You've been muted and your cameras are turned off because we can't run such a large webinar without doing that. But if you do have questions for the panel at the end, please do use the Q&A function. So we'll be working through as many of your questions as possible. So we'll be using polls during the webinar as well. So please keep an eye out for those. And we will be recording the meeting. We'll do our best to upload it to YouTube afterwards. We've managed to do that in previous events. And please fill in the feedback form that I'll share. Share it as a QR code and a link when we finish. So we haven't got a hard stop at 5 because I'm anticipating that it's going to be quite a lot of Q&A and quite lively discussion around this. We understand that you might need to leave at 5. That's fine if you do. But if you don't have to, then do carry on with us for probably another 5-10 minutes if needed. So just a little bit about our network. So it's founded back in 2019 by members of liaison and old age faculties. So since then, over 400 people have joined the network. We've done 3 webinars. This is our 4th. Recordings are all available on YouTube. The link is there. We did a full-day conference hosted by the old age faculty at the college in December 2022. It's something we would love to do again in future years. And at the moment, we're continuing as a cross-faculty working group, but we hope to form a special interest group at the college when there's space available. So I'm moving the mailing list completely over to something called Mail, which is much better because it means that we can all speak to each other rather than us just emailing you. So to sign up for that, lots of you have already, just go to the Mail link and search for Old Age Liaison Psychiatry. If that's too fiddly or you're having problems, you can email me directly on my email address there. Okay, sorry, went too early for that. So without further ado, let's move on to our first speaker. So Dr. Jeremy Cave is a specialty registrar in older and general adult psychiatry, training in the Thames Valley region and currently working at the Warneford Hospital in Oxford. So he recently published a really great paper on this exact topic in Advances entitled Deprivation of Liberty in Hospital, the MHA versus Dole's Dilemma. And I'm going to put the link to the paper in the chat. It's really fantastic. I've used it as a teaching aid quite a lot over recent months. So over to you, Jeremy.
Thanks, Josie. So I'm just going to share my screen. And then once I click go, it should come up on the screen. Do tell me if it is not there. Otherwise, I will assume it is.
It's there.
Fantastic. Great. So yes, thank you for the introduction. It is a pleasure to speak to you all, though incredibly daunting because there are over 100 people, which I wasn't expecting. And looking at the chat, you are all in your own ways experts already. So I'm going to do my best to present the paper in a way that perhaps touches on things that hopefully are new or are interesting, but assuming a bit of prior knowledge already. So I wrote this paper with Alex Ruck-Keene, who is an honorary KC at 39 Essex Chambers, and with my former consultant supervisor, Dr. Matthew Lowe, on my liaison placement last year. And the motivation for the paper was to try and ease an uneasy feeling that seems to stalk me through psychiatry, and I'm sure stalks many of you, which is this sense of, I'm not completely sure where I stand legally here, but there must just be an answer around the corner. And researching and attempting to write this paper was all done with a slightly naive hope that we could kind of get to the bottom of it. And I guess the first disclaimer is that I think there are genuinely ethical, clinical, legal equipoise in some cases, that the dilemma goes all the way up from the kind of shop floor of where we work right up to the lawyers and the judges. So I've included a quote here from Mr. Justice Hayden in previous case law that was looking at the MHA Dole's dilemma. And he concludes by saying there is a pressing need for clarity and predictability at the interface of these two complex regimens. He wrote that in 2014, and it's as true today as it was back then. Nothing particularly significant has changed legally. And so one of the things I think we wanted to reassure people with our paper was that it is possible to be unsure, and it's because it's inherently uncertain rather than there being something that you've missed. And hopefully what this presentation does alongside the paper is kind of to mix a few different metaphors, kind of gives you the skeleton of the dilemma when it occurs, when it doesn't occur, and maybe a kind of landscape on the factors to consider that may lean you towards one legal regimen rather than another. But I think what's really clear when we researched it is that there is no kind of definitive answer for all cases. So to jump straight into it, what is the dilemma? So the dilemma is this really, which is that when we are admitting someone and treating them for their mental disorder, and they are agreeable to that admission, but they lack capacity, we have two possible legal frameworks that we could use to admit them to hospital and treat them: the Mental Health Act or the Deprivation of Liberty Safeguards, which is part of the Mental Capacity Act. On the flowchart here, we show the other kind of permutations that you should all be familiar with. So starting from the left, where someone is agreeable to coming into hospital for admission and treatment of their mental disorder and they have capacity, it would be an informal admission. If they're objecting, they have capacity, but it's still felt to be necessary that they come into hospital, we would use the Mental Health Act. And on the far side, where someone lacks capacity and they're objecting to their admission and treatment for their mental disorder, we would use the Mental Health Act. And we'll touch a little bit more on objection in a slide later on. So it is the compliant but without capacity patient that sits at the kind of fulcrum of this dilemma. And the kind of importance and the impetus behind this, which I feel kind of isn't necessarily spelled out enough to us as doctors, is that ultimately we are agents of the state. So as agents of the state, we have a legal duty to uphold and protect and defend our patients' human rights. And the right that is most important in this kind of legal context is our patients' Article 5 right to liberty and security. Everyone has the right to liberty and security of person. No one shall be deprived of his liberty, save in the following cases and in accordance with a procedure prescribed by law. And the Human Rights Act lists various cases, but one of which, E, is of persons of unsound mind, so those suffering from a mental disorder. And we have two legal frameworks for that. We have Deprivation of Liberty Safeguards, which was introduced following the Bournemouth case, and the Mental Health Act. And it's worth just touching on the story behind the Bournemouth case, because I think it anchors all of this in the kind of human and emotional kind of reality and context, and reminds us that we're dealing with vulnerable adults, despite this being a very abstract and legal kind of topic. So the Bournemouth case was about a gentleman in his 40s, HL. He has autism and a learning disability. He's been in hospital for decades. He is discharged to a foster carer, a couple who love him dearly, consider them one of his own. And for the next few years, he's living happily with them. He will frequently visit a day centre. He goes to the day centre. He becomes agitated. It's the late 90s. There aren't mobile phones. Staff can't get hold of the foster carers, so they call the GP. The GP comes and sedates him, sends him to A&E. The psychiatrist attends, sedates him. He doesn't have capacity to make decisions around his treatment, but he's quite agreeable at this point. So he's admitted to the Bournemouth Mental Health Trust, where he's kept for 3 months without seeing his foster carers, and then a total of 5 months. And the foster carers appeal this, and they go through the UK courts, and ultimately they lose. And then they go to the European Court of Human Rights. And at the European Court of Human Rights, they say HL was deprived of his liberty. He was admitted under common law, but common law is not a sufficient procedure prescribed by law. So the UK was required to introduce a procedure prescribed by law to manage cases such as HL. and safeguard his liberty and security. And so Doles was introduced. So strictly speaking, the dilemma, the MHA Doles dilemma, only occurs in circumstances where the admission and treatment of someone with a mental disorder amounts to a deprivation of their liberty. But I think it's really interesting to just sit with what it means to be deprived of one's liberty. So you should be familiar, I hope, with both the people on the screen. On the left is Baroness Hale, who presided over the Cheshire West and Chester Council case, where she defined what it is to be deprived of liberty with the kind of famous acid test. And on the right is Sir Simon Wesley, who authored the independent review of the Mental Health Act. And one of the things that's most interesting, I thought, about the Cheshire West case is that Lady Hale, lady at the time, explained that we should be considering a deprivation of liberty not when someone has been deprived of their liberty, but when it's considered likely. And what I thought was most interesting about that definition of likely is that it's not a probabilistic one. So it's not 51-49 chance of being deprived of liberty. It's a legal one, which is that there is a, quote, real risk, one that cannot sensibly be ignored. It's open to kind of clinical, ethical, legal interpretation as to what a real risk is, one that cannot sensibly be ignored. Is that 20% chance, 1%, 5%? But it certainly sets the bar much lower for considering when someone is deprived of their liberty. And when that was taken together with the acid test for what it means to deprive someone of their liberty, Sir Simon Wesley concludes in the independent review of the Mental Health Act that when a person is unable to consent to their admission and treatment because they lack capacity, it will almost always be a deprivation of their liberty. So although the dilemma is strictly where we're depriving someone of their liberty, in a mental health context, the feeling is that we're almost always doing that by just the nature of both the disorders we're treating and the context in how we treat patients. So how do we identify the dilemma? So AM versus SLAM is the case law where Mr. Justice Charles, the judge presiding over the case, kind of sets out what he feels are the kind of steps for identifying that there is a true dilemma. This was then kind of simplified into more sort of user-friendly language by our friends at 39 Essex Chambers. And really there are 3 steps. And I guess in their simplest iteration, the first step is, do they fall within the remit of the Mental Health Act, by which we mean, is the person suffering from a mental disorder for which assessment or treatment in hospital is necessary, the kind of necessity test. And we know that there should be corresponding risks as well, either to oneself, safety, others. Does the patient fall within the remit of the Mental Capacity Act and deprivation of liberty safeguards? So does the person lack capacity and need confining to hospital in their best interests, where to do so is proportional to the risks to their own safety? So that's the best interests plus test. And then finally, is the person ineligible to be deprived of their liberty under the Mental Capacity Act and DOLS? Specifically, are they objecting, which is what I'll touch on next. So within the Mental Capacity Act, Schedule 1A, it lists 5 cases, which they call cases A to E, and those describe persons who are ineligible to be deprived of their liberty by the Mental Capacity Act, deprivation of liberty safeguards. So case E, which is most relevant to us and our practice, is that those patients who are objecting to either being a mental health patient or to being given some or all of their mental health treatment and are also falling within the remit of the Mental Health Act, so they're eligible for admission under the Mental Health Act, then they cannot be treated under the Mental Capacity Act. And this was the sort of rationale for this was spelled out in DN versus Northumberland, Tyne and Weir. The judge was explaining that the ethos is that patients who lack capacity should be treated where possible in the same way as those with capacity. So if a patient without capacity is objecting to their care and treatment, then they should be treated like a mental health patient who has capacity who is objecting. And we know that patients who have capacity and are objecting would come under the Mental Health Act. The Mental Capacity Act and the Mental Health Act Code of Practice spell out some of the kind of ways of thinking about objecting as sort of the bar for finding someone objecting to their care and treatment. So one of the things they ask us to do is to consider circumstances from the patient's past. And what I take that to mean is that if we have historical evidence from previous admissions or outpatient appointments that the patient has previously objected to certain forms of care and treatment that we're kind of proposing to implement this time, then that seems to be a sort of reasonable set of evidence to use to perhaps consider them as objecting this time if they're lacking capacity. The objection does not need to be reasonable. It doesn't have to have any particular logic to it. It simply is objection as form. The content of the objection is not what's important, it's that they are objecting. And then the code of practice advises as clinicians that we err on the side of caution. So if we're finding it difficult to work out if someone's objecting, or we're unsure, or we suspect they would if they could, then we should probably be finding them as objecting and using the Mental Health Act. So it's often, objections often pivotal for deciding whether there is a real dilemma or not. So to kind of reiterate, a patient who is at the dilemma of the Mental Health Act and deprivation of liberty safeguards is someone for whom they require admission and treatment for their mental disorder, and it is necessary under the Mental Health Act. It is also in their best interests and proportionate to the risks themselves under the Mental Capacity Act, and they're not objecting. So in the next few slides, I just wanted to touch on a little bit about maybe kind of common assumptions about the MHA and Dole's dilemma, and some of the kind of empirical research that's been done on the interface, and thinking about how it's then resolved in practice and what we're advised to do to resolve the dilemma. So the first thing is that there is both a widespread set of beliefs and assumptions that there isn't in fact a dilemma, and there are also arguments made that there shouldn't be a dilemma. So the first is that I've referenced two authors here, Clare in 2013, which was a Cambridge research group, and Gilbert in 2021, which is a King's Fund commissioned study. Both of them looked and spoke to people who are working at the interface of both of these legal frameworks, best interest assessors, AMPs, approved clinicians, Section 12 doctors, asked them both what they thought of the dilemma, how they approach it, how they resolve it, and their reasons for resolving it. And one of the things that they found both then and now, and it's a position that hasn't really changed over time, is that there is still a fairly commonly held view that if there is a dilemma between the MHA and Dole's, that the MHA simply takes primacy. That isn't the case legally, but it's still something that a lot of people operate by. And I'll hold my hand up. For a brief while, I sort of realized I'd basically fallen into that mindset, particularly shortly after getting my Section 12 approval, this sort of assumption that the patient's for the Mental Health Act if there's clinical equipoise. Similarly and conversely, some have argued, so the lawyers in the AM versus Slam case that set out the three-step procedure for finding the dilemma, those arguing in favour of the patient in that case said, well, isn't the whole point of Dole's that it's for patients who are compliant and lacking capacity? Isn't that the very description of HL's case in Bournewood? And really interestingly, the independent review of the Mental Health Act concluded in their article, in their review, that we should perhaps do away with the dilemma, and where there is a dilemma but the patient isn't objecting, then we should be using the Mental Capacity Act and Dole's. The other findings from the research by Clare and Gilbert were around just generally what we think of both legal frameworks. And I suspect this is a widely shared view within the room. Broadly speaking, clinicians feel that the Mental Health Act has more safeguards, is more restrictive, but is perhaps better attuned to the vulnerabilities of mental health patients, and so better suited to a psychiatric setting. Whereas the deprivation of liberty safeguards are felt to perhaps have fewer safeguards, but also champion autonomy, have a presumption for capacity, so are sort of less restrictive, and so perhaps better suited to a more kind of general hospital setting. I think what's really interesting is that the Code of Practice and case law don't see it in that way. And in fact, they tell us quite explicitly not to see it in that way. So on the next slide, I'll talk a little bit about, okay, well, what is the advice? How are we told to resolve between these two legal frameworks where they appear to be balanced? So the Mental Health Act Code of Practice says that when we're deciding between the two legal frameworks, we should be fact sensitive and case specific, look at the circumstances, apply both legal frameworks to the case, and then appraise one against the other. Which one is the least restrictive way of best achieving the proposed treatment? And in Northamptonshire Healthcare Foundation Trust versus ML, Justice Hayden cautioned that both regimes afford equally rigorous structures, and either one might potentially be suitable on the facts. And in the Mental Health Code of Practice, they're more explicit. Decision makers should not proceed on the basis that one regime is generally less restrictive than the other, nor proceed on the basis that one regime generally provides greater safeguards than the other. When we were writing this article, I think Alex Keane wrote the sort of phrase that we used in the article, which is something like, if this deliberately non-specific advice seems less than helpful, we're sympathetic with our readers. It does seem fairly non-specific advice. And also, I suspect it would be fair to say, and this was written in Gilbert's research for the King's Fund, that it is probably countercultural to a view that's held probably quite widely amongst clinicians, that the MHA is almost never less restrictive than DOLS. But perhaps people in the room have a different view, and it'd be really interesting to hear what you guys think. So my final couple of slides are some pointers that we put into the article, factors to consider that may suggest using the Mental Health Act over the deprivation of liberty safeguards, and then also lists a series of reasons that were given in the empirical research done by Gilbert from the King's Fund that the authors felt are actually reasons that we should avoid and shouldn't be using to decide between the two legal frameworks. So I'll just summarize those briefly. So on this slide, we have factors to consider and ones that suggest the Mental Health Act. So I've highlighted the three that I find kind of most commonly occur and most interesting. Others I'm sure you're familiar with within the box, but I'll go through the three highlighted. So the first is that where a patient's capacity fluctuates frequently, and when they regain capacity, it's unlikely they will consent to their confinement or treatment, then the Mental Capacity Act will be less suitable. Similarly, as with questions of capacity, if the patient is unlikely to remain agreeable to confinement and treatment, then the Mental Health Act will be more suitable. So if someone's agreeing, but it seems highly likely that they won't shortly later or the following day, then perhaps the Mental Health Act would be more suitable. And then the final reason in the box, which I highlighted, which I just thought was, I think it showed how creative it could be thinking about these two legal frameworks, was the conclusions from the Manchester University Hospitals case, which is the most recent piece of case law looking at the dilemma. And there the justice stressed that the Mental Health Act has specific 117 aftercare provisions, and that they're designed to facilitate the discharge of mental health patients where we expect their discharge to be complex or protracted. So where things are balanced, there may be a preference for the Mental Health Act as a way of facilitating someone's discharge. The final slide are the kind of factors to avoid. So Gilbert did research with the King's Fund, spoke to lots of practicing clinicians, and some would cite that they choose a framework because they or their team are just more familiar with it, or they think it's simpler or less burdensome to apply, or they may themselves have a personal preference for one framework or operate within an organization that prohibits the use of a framework in certain circumstances, so limits the use of the MHA in a general hospital or deprivation of liberty safeguards in psychiatric hospitals. And they make the point that where those are the reasons that are being used to decide between one legal framework and another, in the case of blanket rules, I mean, it's not a choice at all, you're not given the option, but it also creates legally arbitrary practice. So as a patient, how you are treated depends on where in the country you are and who you see, rather than the facts of your case and how the law applies to it. And then on the other side of the box, they talk about how in a resource-constrained environment, which is entirely understandable, clinicians may choose a framework on the grounds that it may be easier to find an assessor, or there may be delays in reviews or responses with one framework or another. Or, and I've certainly heard this a few times, it may be that it's felt that the patient wouldn't get a bed in a hospital if they're not under section. And there they talk about how it's an inappropriate use of the law because it's using the frameworks to specifically facilitate one part of the patient's broader care and treatment, rather than considering what is the most appropriate framework that covers all their care and treatment, which is what they're designed to do as safeguards. So I hope that's the sort of landscape and skeleton of the dilemma. The final thing I just wanted to touch on was just some concluding reflections from the paper, or things that I came away with having written it. So the first thing is that I do wonder whether all of this just asks a bit too much of us as clinicians and doctors. I'm sure the room is full of people with an interest in the law and with ethics, but it seems to ask too much of everyday clinicians to not only understand both legal frameworks, which is a reasonable expectation, to apply them individually to a case. I think that is also reasonable, but then to appraise them against each other according to a third standard. To me, that seems to fall into the realm of jurisprudence, and I wonder whether we need legal degrees to do that. The second reflection that was written about by 39 Essex Chambers is that the European Court of Human Rights has a standard of lawfulness, which is that the law needs to be precise enough that as citizens or patients, we can reasonably foresee what will happen to us depending on our actions. And the law is so ambiguous here and complex that as a patient, I'm not sure I would know reliably which framework I would come under in certain circumstances. So does it pass the test of lawfulness, a legal standard of lawfulness? And then finally, I guess there's a question of, is the case law and code of practice actually right? And maybe this is going a bit above my station as a registrar, but I think there's a quote attributed to Aristotle that says, if you want to know about a house, you ask the people that live in it rather than the builders that built it. And we all work within these frameworks. And I very rarely meet anyone who feels that the MHA is ever less restrictive than DOLS. And I do wonder whether the code of practice sends us off in the wrong direction, and whether it doesn't actually reflect our kind of understanding of the two legal frameworks. So that's the presentation, and I will stop sharing it now, and then be able to reconnect with you all, hopefully.
Brilliant. Thanks very much, Jeremy. I love that way of looking at things. We all are.
I just need to stop. Do I need to stop sharing, or am I?
You've done it, Jeremy. You're fine. You've done. Thank you. But you're going to stay with us for the panel discussion, aren't you?
Of course.
And I was just going to say that we all live in the house, don't we? And in particular, our next speaker, who is Dr. Chloe Beale. So she's a consultant liaison psychiatrist at the Homerton Hospital in East London. She's got a master's in medical law, and she's nationally recognised as having expertise in mental capacity, particularly in regard to suicide. And she's given evidence in Parliament on the draft mental health bill. So over to you, Chloe.
Thank you very much. I will share my screen. Hopefully that's all worked. So yeah, thank you, Jeremy. That's a really good, hopefully, way to segue into what I'm going to talk about, which is perhaps a little bit more of how these dilemmas translate in clinical practice. I have a couple of apologies. One is that I'm not very well. I've got COVID, so I really apologize if I cough or lose my train of thought, or otherwise sound like I don't know what I'm talking about. If my presentation is rubbish, that's entirely what the reason is. So yeah, I want to talk about the Mental Capacity Act and Mental Health Act in the real world that hopefully most of us occupy, which is the house. And in this case, in older adult liaison psychiatry. I'm not an older adult psychiatrist, but we do quite a lot of sort of interchangeable work in our team. And I think that a lot of the stuff is equally applicable to older adult and adult, but I've tried to keep a slightly more older adult focus. So I want to start with a case based on something that has cropped up in my practice quite recently, a case of a 70-year-old man who's had a sort of reasonably recent diagnosis of psychosis, has been in a psychiatric hospital once or twice with this, and has relapsed in his psychosis, but also been medically admitted due to an upper GI bleed. He on the medical ward refuses to have a gastroscopy for the upper GI bleed and lacks capacity for this. He really wants to go to the psychiatric ward. It's a place that he feels safe. He knows that he needs treatment for his mental disorder. He's feeling very frightened, but he doesn't want the OGD because he feels that there's a very clear cause for his bleeding. He feels that he is being poisoned through the water supply by his neighbours. And he will be safe on the psychiatric ward, but he also recognises that his mental health is not great as well. Until we can resolve the problem of the investigation, it's not safe for him to go to a psychiatric ward. He needs to be observed and for the medical team to decide what they're going to do about the bleed. He doesn't want to be on the medical ward, but he does want to be on the psychiatric ward. He definitely meets the acid test that Jeremy mentioned for deprivation of liberty. He's got a one-to-one nurse. We certainly wouldn't let him leave if he wanted to leave. A recommendation was made for detention, but he wasn't detained because he was very clearly consenting to psychiatric admission and treatment. So the AMP and the second opinion doctor felt that that was the least restrictive option. So to start with, I wanted to do a poll as to the group, and I apologise. Sorry, I had another apology that I meant to mention at the front. I recognise that this is going to be extremely England and Wales centric, and I really apologise to our colleagues in devolved nations and other jurisdictions. It's often the case that things become very England and Wales centric. I hope that this will be relevant to other jurisdictions, but I do apologise for that. I don't know very much about law outside England and Wales, I'm afraid. So I would be grateful if Josie could run the poll, please, which is which framework do you think that we would use? And, regardless of what the mental health act assessment outcome was, what is your instinct about which framework should authorise the deprivation of liberty in this person on a medical ward? It looks like people are looks like you're swinging towards Doles, actually, which is interesting. Okay, we'll revisit that later. I want to go through things, I want to break things down a bit. So probably many of you, at least if you work in England and Wales, will be familiar with this aspect of the Doles Code of Practice. And of course, Jeremy has already outlined this. So that if the proposed authorisation relates to deprivation of liberty in hospital wholly or partly for purpose of treatment of a mental disorder, the relevant person will not be eligible if they object, as we've discussed, and they meet the criteria for detention under Section 2 or 3. So I want to break that down. First of all, thinking what is a mental disorder? Because we know about the but-for test. So if people wouldn't be in hospital but for the mental disorder, that's something that the GJ case says that but for treatment of mental disorder. So if the person wouldn't be in hospital but for the mental disorder, then they're not eligible for the Mental Health Act, even if they're objecting to that confinement. But what is a mental disorder? Now, we all know that the line between organic and so-called non-organic or functional, whatever you want to call it, is a bit of a fallacy. There's no delineation in the Mental Health Act between an organic and a non-organic mental disorder. And of course, we're dealing with patients with dementia, delirium, knock-on effects from brain injury, stroke, alcohol withdrawal. These are all mental disorders within the meaning of the Act. But what about when the mental disorder and the physical disorder are one and the same? And I think that the law is not particularly designed for the reality of liaison psychiatry, which is often that you can't delineate this at all. Now, in our patient, there's a clear mental disorder and perhaps a clearer sort of separate physical disorder. But as I say, what about when the mental disorder and the physical disorder is one and the same? Then moving on to what do we mean when we talk about treatment for a mental disorder? So some things are obvious, psychotropic medication, ECT, that sort of thing. But what about treating the cause of delirium? If you treat the cause of the delirium, then you treat the mental disorder. So why couldn't that be treatment for a mental disorder for which somebody might be objecting under the Mental Health Act? But then we've all seen patients with very minor triggers or uncertain causes of delirium, and being in hospital alone makes it worse. So if the cause of the delirium is being in hospital, but we can't take people out of hospital, what's the treatment for the mental disorder? And then there's other related medical treatments, which I'll come on to. One-to-one nursing, is it different if the person is one-to-one nursed by a mental health nurse or if they've got a one-to-one with a healthcare assistant or a general nurse? Which one of those tips the balance into treatment for a mental disorder? And what about waiting for placement? Someone touched on that in the Q&A, but what about someone who's sitting on a ward who's been subject to the Mental Health Act or could be subject to the Mental Health Act, and actually the only reason they're in hospital is waiting for a placement, but while being there, they're being one-to-one nursed, perhaps giving psychotropic medication for which they might be objecting or for which they might not have capacity to consent. I would and have refused to apply a section here, but there are patients on psychiatric wards in similar positions who remain under Mental Health Act until discharge or placement. Probably a lot of these people should be on doles, and I suspect that on psychiatric wards we actually underutilise doles. Certainly on adult wards, I think we do. Because actually doles has kind of strayed beyond the remit, which was actually, as Jeremy outlined, for those incapacitated compliant patients on psychiatric wards, but actually it's become a real problem of the general hospital, which was never really taken into account when all of this was being designed. So you see, the idea of what's treatment for a mental disorder is really up for interpretation when you start looking at it. And although things shouldn't be different in different areas, you will find different assessors in different areas who have very different interpretations of what this means. And we don't have the clearest guidance, and it can be very much sort of down to individual quirks, I think, which can be challenging. So the Mental Health Act Code of Practice gives guidance on when you can and can't give so-called physical treatment under the Mental Health Act. So you can't give treatment for a physical disorder. So in this patient's case that we're thinking of, the investigation of a GI bleed, you can't give that under the Mental Health Act unless the physical treatment is intended to alleviate or prevent a worsening of symptoms or a manifestation, or if the treatment is otherwise part of or ancillary to treatment for the mental disorder. I mean, so far so clear, I guess. But actually, in liaison psychiatry, I think that we have a very, very good idea that it's really not that simple. So if we have a detained patient who's on a medical ward for whatever reason, as many of us do, how do we decide which act covers which decision? Assuming, I mean, obviously, we're not assuming that everybody is going to lack capacity for all decisions, even the psychiatric decisions. But just say, so sedation might be reasonably, and other psychotropic medications might reasonably come under the Mental Health Act. Other things sort of becoming slightly more remote, but still related. I would argue that we could probably often treat the results of a deliberate overdose under the Mental Health Act. Artificial feeding is an interesting one. Obviously, we know that that's a very accepted treatment under the Mental Health Act for eating disorders like anorexia nervosa. But I think it's also reasonable in severe depression or psychosis, for example, where someone stopped eating due to paranoid beliefs, or in OCD, or in cases where it's an act of self-harm or a suicide attempt. But it can become more remote because it might be unrelated. For example, in the case of Dr. A, which you may be familiar from in the case law, where he'd been treated from his psychosis, and the food refusal was a very clear capacitated hunger strike. Although I would really caution against diagnosing hunger strike in patients. It's a very significant, it's very specific set of circumstances. So artificial feeding might be, or it might not be, something that you could cover under the Mental Health Act. What about wound care? Maybe, self-harm wounds potentially, maybe someone who's got severe depression and is bedbound and has developed pressure sores. Perhaps could wound care come under that because it's a direct consequence of the mental disorder? What about diabetes management? Another very, very familiar one amongst our patients. Somebody could be self-neglecting due to their mental state. Treating diabetes might reduce the risk of ischemia, cerebral ischemia, or delirium. Maybe the refusal of treatment is suicidal in nature. Maybe all this could be related to the mental disorder. But yet we have lots of situations like this on the medical wards where somebody, has psychosis or whatever and is detained, but we're looking at the physical management through an MCA lens, which is not necessarily the wrong thing to do. But actually, when you start thinking about what is treatment for a mental disorder, that's really, really quite opaque as well. Could we treat my patient's bleed under the Mental Health Act? He's only refusing because he believes he knows the cause, which is being poisoned. So his mental health is directly leading to a worsening physical health. We can make safer decisions about psychotropics and send people to a psychiatric ward where they'll be better treated if their physical health status is improved. And I think that you could possibly technically argue anything. Now, there is a poll here, but I don't know if we can get it up. So I'm going to ask.
I'm going to have a go.
Out of interest, on the last two, what do we think about the reasonableness of somebody it does work. Could we use the Mental Health Act to authorize neuroimaging to assist diagnosis of a mental disorder? And a further step, and this is, I admit, slightly less relevant to older adult psychiatry, but just in general, could we use the Mental Health Act to authorize a cesarean section? I'm going to give you a few seconds to answer that and see what you think. I'm hoping I'm going to know when it's completed because I can't see anything changing yet.
It's still moving. People are still answering, so I'll give you 10 more seconds.
I apologize. It's just a yes, no answer. There's no free text.
Oh, we're forcing you to make a decision. Okay, I'm going to end it now and share the results.
Okay, so yeah, that's, I guess, the balance that I would have expected. And as I say, it's I'm surprised that there's that many people have said yes to the cesarean section. So what does the case law say? And now this is old case law, it's Thameside and Glossop's nearly 30 years old. And arguably this probably wouldn't happen now because we've got the Mental Capacity Act now, which people would probably use. But it hasn't been overridden. This is still, the law. So the case law has held that induction of labour and cesarean section could be treatment for schizophrenia for a woman who was not consenting, and because delivery of a live baby would be necessary for her recovery from psychosis, and she needed to be able to take medication that she couldn't take in pregnancy. Conversely, a much more recent case found that the Mental Health Act could not authorise someone being transported from a psychiatric hospital where they were detained for in mental disorder under investigation in order to be investigated for that mental disorder, which is causing the mental disorder. So does that undermine what we've said about perhaps treating the underlying cause of delirium couldn't be carried out? But I think that what these cases illustrate is that it's very woolly. There's not a clear answer. And it really does seem very much down to interpretation, which is not massively helpful to us on a day-to-day basis. I think it would be highly unlikely now, I'm willing to be corrected, that you would find many people arguing for something like a C-section under the Mental Health Act, simply because we do have the Mental Capacity Act now with very clear frameworks. And I think that would probably be used in that situation. But it has been done. So then to go back to some of those things that we were talking about in terms of whether something's Mental Health Act and DOLS. So what's objection exactly? We know that if somebody is objecting to the confinement or treatment for the mental disorder, then it's not really DOLS, it's Mental Health Act. But what is objection really? Is it just saying that you want to go home, which is pretty much most people in hospital, I think? Is it gentle wandering aimlessly? Is it someone saying I want to go home but without attempting to leave? Or is it someone attempting to leave without actually saying anything? Is it turning away when a doctor comes near them? Is it just being generally belligerent and grumpy? And I think this as a whole kind of pretty much, describes the mix of things that you will encounter every day on your average elderly care unit. And we're not detaining all of these people under the Mental Health Act. We're certainly not detaining in medical hospitals everybody with delirium and dementia. And I wouldn't argue that we should be, but possibly we should be considering it more than perhaps we do. And again, I think that there's probably a bit of variation. So what about our patient? He's objecting to medical admission, but not psychiatric admission. He's very much the incapacitated compliant patient in that way, which is what DOLS was designed for. But is he within the scope of the Mental Health Act? He lacks capacity for his mental disorder, but he's not objecting. But also he's very clearly saying only that he wants to go to the psychiatric hospital, and he can't go to the psychiatric hospital. So it's quite a difficult one. I think that, you know, if we sectioned every older adult with delirium or dementia, or tried to, everyone who's sort of wandering towards the door or is having to be sort of gently encouraged back to their bed, I think that, I mean, apart from anything else, I think we'd be pretty unpopular with AMPs. But I think that you have to be able to say that you're treating someone for a mental disorder. And I would tend not to say that this includes things like sitting on a ward waiting for a package of care, but other people will disagree. And many patients with delirium will be very clearly objecting, and treating the underlying illness could reasonably be treatment for the mental disorder, as well as medications aimed at alleviating the symptoms. And maybe this is permissible under the Mental Capacity Act if it's brief, but if it becomes significant restriction or prolonged to the point of deprivation of liberty, you might be heading into Mental Health Act territory. I think the difficult thing is that there aren't clear answers, and I wish there were, but as Jeremy's already outlined, I think that we can only think about these things in detail rather than say this is what you should do under each scenario. So in summary, I think that there's a much broader definition of mental disorder than we're traditionally encouraged to think about in psychiatry. And I think certainly in liaison psychiatry, this is something that you'll be very well aware of, and older adult psychiatry generally. But basically the way the laws are written assumes this, you know, this complete divide, which we all know is a fallacy, that you can completely delineate what's physical, what's mental, you can treat them separately. You know, mental disorder is something that doesn't exist in the brain or the body at all. It's, you know, somewhere over here, I don't know what, created by fairy dust or something, but definitely not physical. I think we have to have really pragmatic definitions of what is treatment and what is objection. And it is difficult. I can't say what I think they should be or what they are in any given circumstance. But we have to not make these decisions based on sort of gut instinct or our own comfort or ideas about stigma. I think that sometimes, like in the case of a patient where you could probably argue their physical treatment under the Mental Health Act, I would say a belt and braces approach in that scenario is to utilize the Mental Capacity Act as well, by which I mean the MCA and not DOLS. We're not talking about deprivation of liberty here, but I think sort of treating something as a Mental Capacity Act decision, even if the Mental Health Act's in play and even if you might be able to argue it, I think it's safe to go. I think it's a good idea to go down that capacity assessment best interests framework. And the other thing that you have to think about is that what's also difficult is that as psychiatrists, giving treatment under the Mental Health Act that we're familiar with, that's our decision and we're administering it. So psychotropic medication, ECT. But it's quite hard if you're trying to persuade somebody who's unfamiliar with the Mental Health Act territory and the idea of forcing, you know, physical intervention on someone, that they can do this under the Mental Health Act. So that's another way that it's quite difficult and doesn't marry well together, because actually the Mental Health Act kind of assumes that the RC or the, you know, the AC or the consultant in charge of care is going to be the one making all of the treatment decisions that you give under that. But it's not quite as simple as that. I think, as Jeremy's pointed out, the choice of legal framework can't be based on personal comfort or concerns about stigma. And that's something that I think I've certainly come up against a lot, and I'm sure that many of you have as well, is people being very uncomfortable with the idea of using the Mental Health Act in acute hospitals when they're more familiar with DOLS and they feel that it's very stigmatizing. And I will also agree, one of the hardest things that I ever did, what felt awful, was detaining someone under the Mental Health Act with terminal cancer and a rip-roaring delirium on Christmas Eve. It was horrible, and trying to explain to a family what that means. And but actually we have to not respond to our own discomfort and sort of internalized stigma there. Ultimately, it was the right thing to do, given the degree of deprivation of liberty and treatment against somebody's will. But people get very worried about the Mental Health Act and think that it's going to do patients damage in the future if they've got that sort of on their records. And I think the other thing to remember is to escalate disagreements. If you think that somebody should be under DOLS, and you've got a DOLS assessor or best interest assessor who's saying, no, I think there's a Mental Health Act, or vice versa, you're not obliged to apply a legal framework that you feel fundamentally, uncomfortable doing. Escalate these disagreements. Legal teams are there for a reason, and you should utilize them. And actually, that's what they're there for, is to help and, sort these things out. You're not supposed to go through this stuff on your own. These complicated decisions should be made in a very multidisciplinary and multi-professional way, with I think as many senior eyes on as possible. Helpful senior eyes, that is, people who know what they're talking about. So just for a final thing, we didn't really get a poll from the first one, but I would just be interested to know at the end if what people think about my original question about the patient, as to whether the appropriate legal framework was Mental Health Act or DOLS.
So Chloe, we did actually get quite a lot of responses in the chat, which was very helpful, and I have been divvying them up, and I can tell you that we had 58 people answer. 34% went for MHA and 66% went for DOLS.
Rand, could I possibly repeat the poll now?
Relaunched it now. So slightly different.
So great. I'm glad about this, that it's sort of reversed, because that's what happened. So it was a bit of a dilemma, because it was a situation that I'd not come up against before, this idea of only objecting to the physical and not to the mental, but definitely incapacitated. Not objecting to mental health treatment, but lack capacity, but thinking about some of the things that Jeremy was talking about. So the risk of becoming non-compliant or requiring restraint, the recall powers, because this is someone who would have been judged to be extremely concerning if they'd left hospital, and also worrying about the fact that unhappiness with being on the medical ward may lead to him leaving. A good chance that he would end up needing to be treated under the Mental Health Act because of the trajectory of illness. So obviously met the patient necessity test and the best interest plus test, and was ineligible to be deprived under the Mental Capacity Act, I think, because of objection. And I think at that point we thought, well, he needs to be on the medical ward for treatment of the mental and physical disorder. And ultimately the mental state declined, and it became much more obvious that it was a Mental Health Act. But I'm glad to see that it's a sort of a bit of a balance for all of the audience as well, because it was a bit of a head scratcher for me, and I'm glad that the majority came round to what was originally my way of thinking. And that's it. I will stop sharing my screen so we can go to the panel discussion. Thank you very much.
Fantastic. Thank you very much, Chloe. It's all kicking off in the chat, which is great for what we wanted. So we've got our panel that have come on screen. I want to introduce you to someone else who's a very important member of the panel, Gemma Jones, who is an AMP team leader in Surrey County Council. Thank you very much for joining us, Gemma, and giving
afternoon, everyone.
Perspective. So we have got a few questions in the Q&A, but actually quite a few bits in the chat as well. I think just want to start with you, Gemma, if that's okay, just because I think as you were listening to this MHA versus MCA dilemma in the polls, you had quite a strong view about the MHA. Would you mind sharing that?
Yes, yeah. So, I mean, I was thinking that it was Mental Health Act from the start, because I think you are treating his mental disorder. Yes, there is the physical health side as well, um, but I think, yeah, from the information I had, I would have detained him under the Mental Health Act to the General Hospital, and then the GI investigations would have been done under the Capacity Act, because I think to me, he was basing his decision on a delusional belief, which would say that he wasn't able to weigh up and use that information in order to make a capacitous decision. Um, so yeah, so I think you would have had the Mental Health Act to be able to treat the mental disorder, and to be depriving him of his liberty, but whilst he was still undergoing the investigations under the Mental Capacity Act. Um, so yeah, so for me, I was quite surprised at the outcome of the Mental Health Act assessment that was not detainable.
That's a good point that actually a couple of people have made and sent direct messages about. We haven't discussed the utilisation provision of both options in the general acute setting. So according to the decision, using a different frameworks. Just wondering if any of the panel got thoughts on that.
Yeah, I think I did mention not so much DOLS, but the Mental Capacity Act for medical decisions. And I think that sometimes it's something we might consider, for example, if someone's transferred from a psychiatric hospital where they're detained and then put on Section 17 leave to the acute hospital. I think those are probably cases where we should be, if we're not transferring the section for whatever reason, sometimes because the admitting hospital isn't a detaining authority or whatever, but need to consider whether somebody should then be subject to a DOLS when they're in the new hospital if they're on Section 17 leave from somewhere. Yeah, I think both Mental Health Act and DOLS. I mean, I guess you might see that with somebody who's on a CTO who gets admitted to a medical ward. CTOs are a nightmare in the liaison setting, in my fairly limited experience. But yeah, I think that like I said, it's probably not it's probably not what what you would find in the code of practice, but I think a kind of belt and braces approach. Obviously, you can't use Mental Health Act and DOLS most of the time because it's about the deprivation of liberty. But in terms of the treatment, I think that sometimes it's very sensible to use the structure of the Mental Capacity Act when making certain decisions, even for somebody who's detained, and even if maybe you could use the Mental Health Act.
Well, thanks, Chloe. One thing that I thought would be good to bring up is a proportionality of restriction again. So Susie Lingwood put a question in the chat, and I think Jeremy already gave a little bit of a response, but it's this is one that I come across a lot. So someone who's receiving IM medication quite a lot, and there may be different degrees of objection to IM, different degrees of restraint involved. My own personal take is that you probably get away with it once in an emergency, but then you really need moving into MHA. Just wondering about the panel's thoughts on that.
I know you mentioned, Josie, that I'd said something in reply to it. It was in fact to ask the panel, so I will defer to the rest of the panel.
What do you guys do as practicing liaison consultants?
And I'm afraid I was slightly distracted by reading something in the chat, so I didn't hear the question.
Sorry. You're right, Chloe. It was about using IM and when are you moving into MHA? So for me personally, if somebody's needed it once in an emergency, okay. But then if it's becoming a repeated event, then I'm very clearly going down the MHA route for that person.
I would have a similar approach. I don't think that there would be any sort of particular number, but I think, if somebody comes in and the first encounter you have with them, they're very agitated and you use IM medication for a day, and then day 2, you're still needing IM medication, I think once you're heading into day 2, day 3, I would be preparing for a mental health act assessment, particularly if that also involves that person being restrained, having to be kept in a separate place from other patients, and if their agitation is both a risk to themselves and to other people around them. I think that then you do kind of enter mental health act territory. So those are the sorts of considerations that I would have.
Yeah, and I also think it's the because I think there is a general view with many who think that the Mental Health Act is more restrictive than the Mental Capacity Act, but you've got a much more instantaneous access to appeals, you've tribunals, your nearest relative. Whereas if you were going to be under doles, you could be under an urgent doles before it's even assessed, and then that can take some time, depending on which local authority you are with. People in general hospitals aren't always prioritised to have the doles authorised, and then you have to have the RPR to go to the Court of Protection in order to say, if you think about how much treatment could be enforced on that person under a doles versus the Mental Health Act before it's actually reviewed, and also you've got the SOAD that would be for particular areas of treatment. So I think actually it's, if you sort of think about a rights-based approach, the Mental Health Act is actually, or could be considered actually less restrictive than the Mental Capacity Act, and have a lot more safeguards for the patient as well.
So relevant question from Carol Wiltshire based on that point is, do we feel the term least restrictive is vulnerable to abuse or weaponization? What do you guys think?
I love that question, and that really ties in with the biggest bee in my frankly enormous bonnet, which is about the use of someone saying a person has capacity to my particular interest is people being told that they have capacity to kill themselves, therefore aren't going to get any help. But this is something that was seen right back at the House of Lords post-legislative scrutiny of the Mental Capacity Act, and then in the Wesley review of the Mental Health Act, this idea that having capacity is weaponized in order to justify an action. So across the board, in all sorts of settings, if you say, oh, they've got capacity to make an unwise decision, then you don't have to do anything. And obviously, I'm not saying that's how it's universally used, but it can be used, particularly in a system which has no resources. So yeah, I definitely think least restrictive has that risk. And I see it used a lot. I think it's really interesting. It's a Mental Capacity Act term, but it's just sort of splashed across notes everywhere in every context, isn't it? Regardless of what the decision is, discharge home as least restrictive option, or, home treatment team as least restrictive option, or whatever else it is. So I think it's already becoming overused, but also like positive risk taking, like gatekeeping, like patient flow. These are all kind of terms which can be used to say, get rid of the patient, we're being the least restrictive option, we're positive risk taking. I think all of these things are fine concepts in and of themselves, but I think that we definitely run the risk of overusing the concept of least restrictive and potentially using it to let ourselves off the hook.
Yeah, and also the Mental Capacity Act says less restrictive, that doesn't have to be least, and the Mental Health Act says least, and I do think when I'm training trainees, I always say there is a real difference between the word less and the word least, and I think they are used interchangeably, and they're not interchangeable terms. But I also think like the presumption of capacity is used as a defence for. And it's so people with a severe mental illness who are on the verge of a mental health assessment or on the verge of a psychiatric admission, you should be questioning their capacity because they have a severe and enduring mental illness that may be impacting on that. So I think that, I think this goes along with what you were saying, Chloe, and it's sort of, those are the terms that mental health professionals should be using, because they are a meaningful term of what we are actually applying, not just as a general catch-all, because I think that could be quite a dangerous thing to be using it when you're not actually fully understanding the meaning of the word.
Brilliant. Thanks, guys. Chris, you want to say something?
I agree. I think that's one thing, like, you've got some legal framework, but people use the terminology to their advantage, which we see it every day in, day out in clinical practice. Like, again, least restrictives, definitely one of them, they mold it along the decision already they have made. And the other one is about they have capacity, which we find it's almost like that's the decision to send them home. That's the decision not to admit into a mental health facility, or various things which we see in both in crises as well as in some of the liaison, out of hours, saying that they have capacity, so we're going to send them home. When actually, again, this is where the Mental Health Act elements come into play, like the nature and degree. If somebody has had a chronic enduring mental illness, they've had a medical reason why they are in a delirious state and in hospital, and the future treatment might lie in a mental health facility, but sometimes the delirium is clear, they have got capacity, they can go home, when actually the mental illness must have deteriorated significantly, which we have seen. And the other point which also need to be mindful is that sometimes as liaison psychiatrists we might have to detain them under the Mental Health Act and admit them in our hospitals, rather than using the MCA to carry on continuing in an acute hospital. Those things can happen. Somebody put in, it may not be the dichotomy of one or other. Could we have all of the above, like, bit of Mental Health Act, bit of mental capacity, and some of those things that might play. So Chloe, you really nailed it, saying that some of these words are used as a weaponizing mechanism to disadvantage patients rather than actually following the law to the degree. Thank you.
And there is something about, Carol's put a point about this, it's about the convenience of how it best fits the situation. So one thing that really concerns me is how rare it is now to have someone admitted informally to a mental health ward. And I do worry that often we go for MHA because it's a lever to get a bed when it's extremely difficult to get a bed. And I can see that happening much more over the last few years. Just wondering if panel have got any views on that. You're all nodding, so I'm guessing I'm not alone in that observation.
Well, it's a universal phenomenon now. You will be taken to third degree questioning. People get really surprised when you want to admit a patient informally. Immediately they think that you have not done your job. They think informally you want to admit, have you tried this? Have you tried this? And then they try to teach everything in the book that you have read for the past 25 years. So it does, it does sometimes, this is where I talk about nature and degree. If I know this patient is going to deteriorate with the nature and degree, I'm trying to get the patient consent, shared decision making, to get the patient on board to get that emergency treatment as an inpatient. No, it needs to be a Mental Health Act, and I do find it very worrying. The other question to also ask is, some of the older adults are disadvantaged because they don't get admitted out of hours, saying that they have capacity, or the family, or they've got a least restrictive place to stay tonight. So emergency admissions are sometimes even deprived for older adults, using the same legal terms in a negative way. Thank you.
So I'm going to carry on for another 5 minutes or so, and we've still got 150 people with us, which is fantastic. I just want to go back to the whole waiting for placement or care package type scenario, where you might have people in what you think quite similar situations, but they've ended up waiting for a care home placement in a mental health bed, or they've ended up waiting in an acute hospital. And if they're in an acute hospital, they're probably not going to be under section, whereas if they're on a psychiatric ward, they probably are still going to be under section. And the kind of gateway that Section 3 gives you to 117 aftercare and the funding, I think when resources are so scarce, it's extremely difficult not to let that impact on your decision making. So I was hoping for the panel's thoughts on that. Annabelle.
I think probably one of the most challenging and contested situations I found myself involved in clinically was with a patient who had a diagnosis of bipolar disorder and then a diagnosis of a vascular dementia on top of that, whose behavioral and psychological symptoms of depression and the sort of some of the ongoing symptoms of their bipolar disorder meant that actually it was very, very difficult to find a placement that would be able to meet their needs. But a psychiatric admission was not really going to change things, and they ended up being in an acute admission in my hospital for about 18 months, and being able to gauge the right legal framework to manage their care, which encompassed everything from mental health medication to continence management to feeding to managing risk to members of staff who frequently had things sort of thrown at them. It actually was very challenging, and there was a huge amount of disagreement around what the legal framework should be to care for this person, and not only that, but also around how then to take that person safely when we finally did find somewhere. And I'm not sure that I think for that person there really was, a justification for either legal framework, and it really was very, very challenging. And in fact, during the course of the 18 months, both DOLS and the Mental Health Act were used at different points in time, and so that particular experience really did show me that even within the same set of circumstances, there may be very small changes that may tip you from using from one legal framework being the most appropriate compared with another, and also the very strong feelings of the family also were a really key consideration in the thinking around it. So those sorts of situations where you have both pre-existing enduring mental disorder and dementia and delirium on and off, I think really is kind of the quintessential difficult dilemma situation.
Thanks, Annabelle. Any final thoughts on that? If not, I'm going to close off because we're coming up to quarter.
I think Anthony summed it up quite well. Although there are no definitive answer, I'm finding all this discussion very validating and reassuring. I think we have succeeded in our mission. I think we are here to have that discussion of experts and validated papers. Still, when you have a patient in front of you, the dilemma remains, but at least so that you're not alone among with all the 200 people here that trying to see what best we could do for the patients, and also what things we shouldn't be doing is the key thing, isn't it, Josie?
Absolutely. Now,
yeah,
so there's a QR code if you find that easier. Some questions about access to recording. We are recording. It's going to be quite a big file. I'm going to do my best to upload it to YouTube. That's what we've done previously. And then we'll send the link out to our network as well. So thank you very much for joining, everybody. You're most welcome. Hopefully we'll see you at future events.